Morning.
Morning.
A little bit of history to begin with. Many years ago, this Fairview Recovery Services at Riverside here was two hospitals. Fairview Hospital, which is the west building, and the east building was St. Mary's Hospital. St. Mary's Hospital had a treatment program, St. Mary's treatment program, which is now this treatment program, and it's nationally known. It was known as one of the best treatment programs in the country. And we got people from all over the country to come to treatment at St. Mary's. I was doing my family practice residency here, becoming a family practice doctor. And my mother in Cleveland, Ohio, had alcoholism, and my brothers and sisters were all asking me, what can we do, what can we do? So I thought that I needed to learn something about alcoholism. So I started to take rotations on the treatment program at St. Mary's when I was a resident. And I did that in my second year, and then I did another month in my third year. And then when I went into practice as a family practice doctor, they needed a doctor to take care of the patients that were in treatment. So I started to do that. And I needed to learn about addiction, and I needed to learn about detox and withdrawal and what to do. So I took courses in addiction, and I went to national conferences and such. Within a short period of time, I became aware that I had this disease too, so that made me even more interested in learning about addiction. In 1988, the medical director, the original medical director, Dr. Mann, retired, and then I became medical director. And I did my family practice, I did my medical directorship, I took care of patients on the treatment program, all at the same time. Up until about 4 or 5 years ago, I stopped the family practice. And now I do just addiction medicine in an office next door. We used to just have myself, but then we now have 3 doctors, and now we're going to have 5 providers in addiction medicine in the clinic next door. I will stop being medical director next month, October 1st, and Dr. Hubble will take over. Alex Hubble will be our new medical director. Why don't you give him a hand? All right. So, over the course of my career in addiction medicine, the whole field of addiction medicine has grown. Doctors have learned more about it. We really know a lot more about what addiction is. We know what you have. We know addiction is a disease. It's a disease of the brain. It's a disease of the part of the brain that is involved with reward and reinforcement and pleasure. It's a disease of the brain that involves neurotransmitters. One of the main ones is dopamine. There's a difference between the people with the disease and the people without the disease. The people without the disease have a normal level of dopamine. People with the disease, they're kind of born differently. They remain differently. And it's like a pilot light that never goes off. The disease is always there. We put people to treatment, but the disease still stays there. You get in recovery, but the disease is still there. People with the disease have either a less amount of dopamine, or the dopamine is eaten up quicker, or it doesn't work as well, or it doesn't bind to the transmitters as well. So they're left with this, what we call low dopamine tone. That makes people with the disease feel less than, apart from, different than the rest of the population. The rest of the population feels fine. They use a chemical like alcohol or opiates, and they get high, and then they go back down to normal. No, not that big a deal. They control their use. People with the disease are feeling low. They use a chemical, whether it's alcohol, opiates, benzos, whatever, and they go up to normal, and that feels absolutely fabulous. And then they go higher than that, and that feels even better. And then when they crash, they don't crash down to normal, they crash down below with the disease again. So they keep using and using and using. And that's what addiction is. It's continued use, despite problems, it's loss of control, it's the powerlessness. So we in addiction medicine understand this disease, and we know we've learned a lot about how to treat it. What I'm going to do is talk about the major chemicals that we see. The first thing we need to do when we have somebody with this disease is get them to stop using. And when people stop using their drug of choice, they're going to go through withdrawal. So I'm going to tell you a little bit about the withdrawal from these drugs. I'm going to tell you how we detox people. And then MAT means medication-assisted treatment. So you go through detox, you go through withdrawal, you get off the drugs. But unless something is done, unless there's a good treatment, unless there's a good recovery program in place, unless there's medication frequently, people are going to relapse. They're going to go back to using what they used to use. Relapse is common. What we would love is as if there were no relapse. The relapses didn't happen. So that's our goal, is to get people into recovery, have them be in recovery, stay in recovery for the rest of their lives. The medications help somewhat, and I'll explain how they do help. But the core to treatment, they come in here and you learn about the disease, you learn about what's happened, you learn about what's happened to the people that you live with, you learn about the consequences of your use, you learn about recovery, you learn about ongoing meetings and ongoing support. Spirituality is a big part of recovery. Spirituality through the 12 steps actually raises that dopamine so that you can feel normal like other people without using any chemicals. So that's part of the treatment. Alcohol is still the most common drug that we see here. Of all the withdrawal syndromes, alcohol is the most serious and the most dangerous. It's the one we worry about the most. It begins about 8 hours after the last drink. That's the tremor stage of alcohol withdrawal. This is the hangover stage. In this stage, people will feel nauseated. Blood pressure will go up, will get sweaty, will get shaky. That's why they named the stage for the tremor. If a person with withdrawal puts their hand out, it won't be steady like this. It'll be shaking. The alcoholic usually in this stage wants to be left alone. They minimize their withdrawal. I've seen people that are just shaking tremendously, and you ask them how they feel, and they go, "I feel fine, Dr. Amer, I feel fine." But they're shaking and sweating. If it goes on, it goes into stage 2, the stage of hallucinations in alcohol withdrawal. This happens more frequently than you would think. The doctor sometimes has to ask about it, elicit it, or the patient won't talk about it. The hallucinations can be any of the senses. They can be visual hallucinations, seeing things that aren't there. Auditory hallucinations, hearing things that aren't there. Tactile hallucinations, feeling things that aren't there. Sometimes alcoholics will feel things crawling on them, or something underneath their skin. That's why you will see them brushing themselves or picking at themselves. The visual hallucinations are usually frightening. They don't hallucinate flowers and sunsets and things like that. They hallucinate people coming after them, something threatening, something terrifying. So they usually get terrified when they're having these hallucinations. And auditory, they will hear voices giving them commands, telling them to do something. So the alcoholic having the hallucinations is usually very terrifying. The third stage of alcohol withdrawal is the stage of seizures. A person can go right into seizures without having hallucinations and with actually having minimal tremor. And usually it goes into the through the stages. A seizure can occur right away, even before a person's blood alcohol level is before it's down to 0. So if a person's drinking a liter of vodka per day and they cut down to half a liter, they can have a seizure. And it can occur up to about a week after the last use. Anything beyond that is probably a seizure due to something else. The seizure of alcohol withdrawal is always what we call a grand mal seizure. It's not shaking, it's not staring off, it's a grand mal. So if I'm it's a complete and sudden loss of consciousness. So if I'm suddenly unconscious, I'm going to fall and I won't break the fall. It's not like a fainting spell where you slump to the ground. It's falling like a tree. If a person is in a chair, they will fall, straighten up and fall back. If they're in bed, the hands will go up real quickly and the legs will get tight. It's called tonic-clonic activity. Their mouth will clamp down really quickly and they may bite their cheek. They might bite their tongue. They're not going to swallow their tongue. That's a myth. They're not going to, the bleeding is just going to be a little cut. It's nothing to worry about. It's a myth. when you hear that you should stick a stick in the person's mouth, all you're going to do is damage the teeth. The mouth is already clamped down. The person won't swallow during this seizure, so you might see spit coming out of the mouth. The saliva coming out is actually where the expression foaming at the mouth came from. The seizure will last 30 seconds, maybe 45, maybe a minute, and then the person will relax, wake up, and wonder what happened. And they will have no memory of what happened during the seizure. If somebody is talking during the seizure and saying, I'm having a seizure, I'm having a seizure, then you know it's what we call a pseudo seizure. It's fake, because a true seizure, the person is unconscious. The seizure is not dangerous in itself. And in fact, the danger is usually the fall and the injury that can happen with the fall. But usually the withdrawal is a little less. It's like pressure has been released. They do a little better after the seizure, but obviously we want to prevent them. The fourth stage of alcohol withdrawal is the stage of DTs, or delirium tremens. And this is what we try to prevent. This is one of the main reasons why we have detox units, why we monitor people carefully and take vital signs and give lots of medication. We want to prevent people from going into DTs. DTs is a medical emergency. DTs can result in death. It used to be 1 out of 4 people in DTs died. It's not nearly that much anymore with the advancement of intensive care units and treatment, but it's still very dangerous, and anybody in DTs will get transferred to the intensive care unit. In my career, I saw 3 deaths right in front of me, people I was taking care of on the unit while I was there from DTs. Something I'll never forget and don't ever want to see it again. Haven't had a death in a long time, but it is a very dangerous medical condition. DTs is like the brain being on fire. We have 2 parts to our nervous system. The central nervous system that controls our thinking and our movement and our touch. And the autonomic nervous system, which controls our blood pressure, pulse, sweating, temperature. In DTs, both go into overdrive. There's this adrenaline surge, and the people will be delirious. They won't know who they are, where they are. They won't sit still like you all are. They become extremely agitated, and their vital signs are going very high. And when they die of cardiovascular collapse, because the blood pressure can go so high, and the pulse can go so high, and the temperature can go so high. So DTs is a medical emergency. The last stage of alcohol withdrawal is actually the last stage of all the withdrawal. It's called the protracted abstinence syndrome. And many of you here, if not all of you, are in this stage now. And this simply means that despite being out of detox, your vital signs are good, you're feeling okay. The withdrawal does not completely gone yet. It can last for a month, 2 months, 3 months. It's the protracted abstinence syndrome. It's also called post-acute withdrawal. It's also called early recovery. And this stage is so important because relapse can occur in this stage so frequently. Patients will have in this stage the symptoms of sleep disturbance, eating disturbance, gastrointestinal disturbance. They just won't feel well, and probably most importantly, mood disturbance. There'll be lots of anxiety in this stage, lots of depression in this stage. And people are actually misdiagnosed as having a mental illness like major depressive disorder in this stage when they don't have it. They're just in a protracted abstinence syndrome. And if they can stay sober for a month, 2 months, 3 months, 6 months, it all goes away. 80% of the relapses occur in the first 6 months. 80% of the relapses occur in the first 6 months. So if somebody can get through this stage, their chance of long-term or lifetime sobriety is much, much better. Any questions about alcohol withdrawal? Benzodiazepine withdrawal. People get addicted to benzos, which we actually use to treat the alcohol withdrawal, which I'll talk about in a minute. Benzos are used for anxiety. Common one is Valium, Ativan, Xanax, Klonopin. They're prescribed for anxiety, for panic disorder. When people are prescribed them regularly and they come off of them, they will have a benzo withdrawal. Addicts will take them and become addicted to them. They work on the same part of the brain as alcohol. They work on the GABA receptor, and when the person comes off of it, they will have a hyper state, a state of anxiety, a state of panic, a state of nervousness, insomnia. Patients in benzo withdrawal don't have the seizures and the delirium that alcoholics have, at least not usually. They have a lot of psychological symptoms. They will be very anxious, feel like they're in the wrong place, and it's pretty intolerable. So we need to treat that. People coming off of stimulants, cocaine, methamphetamine, we used to say it doesn't really matter because the withdrawal is always the direct opposite of the drug of choice. So in alcohol withdrawal, benzo withdrawal, opioid withdrawal, those are all depressants. And this withdrawal is the state of excitation. But with the stimulants, the withdrawal is this crash stage. Patients will sleep more in this stage. They will eat more in this stage. They will eat, go to bed, get up, eat, go to bed. They will sleep a lot. So usually there's not a lot to worry about in the stimulant withdrawal. People coming in that are still high from a lot of meth use, they will be agitated and paranoid and psychotic at times. But that's not withdrawal, that's just continued effects of the drug. Marijuana, again, we used to say there's no marijuana withdrawal because it leaves the body so slowly. That the marijuana today is much, much stronger and much higher concentration of tetrahydrocannabinol than it used to be. So some people stopping marijuana will actually get what's called cannabis hyperemesis syndrome, which simply means this repeated episodes of vomiting, unable to keep fluids down, unable to eat, and they can get quite dehydrated. And then the last one is opioid withdrawal. Where there's an opioid epidemic. Many of the patients coming through detox, going into treatment, are addicted to opioids. The opioids can be prescription opioids, such as oxycodone, hydrocodone, Dilaudid, tramadol, which is also called Ultram. All of those are opioids, and the withdrawal is the same. And then the common non-legal, non-prescription opioid is heroin. Now we're seeing a lot of fentanyl. The withdrawal is similar for all of them. The withdrawal from an opioid begins about 24 hours after the last use. At this stage, the person will start to feel sniffly, achy, not feel well. When it gets to 48 hours after the last use, they won't be able to sleep. And then they go into the peak opioid withdrawal. Opioid withdrawal has been described as being hot and cold at the same time. When you ask an opioid addict how they feel in withdrawal, they say they feel like they're going to die. They're not. They're not in as much danger as the alcoholic, but they feel that way. It is intolerable. It is scary. There's a tremendous amount of fear that comes to the opioid addict as they go into withdrawal. And they've got to get it to stop. It is that bad. It's been described as like a bad case of the flu, but it's much worse than that. It's a lot of fear. So they continue to use in order to get through the withdrawal. It can last a long time. It can last a week if it's untreated. Sometimes people coming off of Ultram or tramadol will last for 10 days or more. So the people coming off of methadone, it can last for a month or more. So that's opioid withdrawal. Not dangerous, but very intolerable. They will get bone pain, muscle pain, nausea, vomiting, diarrhea. Those are other symptoms. So that's the withdrawal that the people feel. We bring them into detox or into our office, and how do we get them off of it? For alcohol withdrawal, if I see somebody that's using not too excessively, they have somebody that they live with, somebody that can watch them, and I don't think that they're going to go into DTs or have seizures, I can actually treat them as an outpatient, prescribing gabapentin, and then seeing them back the next day, seeing how they're doing, and then seeing them back the day after that. We can do a gabapentin for 4 or 5 days and get them off. It's called outpatient detox. But anybody that's having serious withdrawal, and I'm worried about them going into seizures and DTs, they need to go into the hospital to a detox. And there, the main drug of choice are the benzodiazepines. Like I said, it goes to the same receptor, so actually it will be very effective in treating alcohol withdrawal. We used to use Ativan, but now we use mostly Valium because we like how long Valium lasts. It lasts for weeks, and it gradually leaves the body, so there's this slow taper, and they don't go back into a rebound withdrawal. We just give as much as somebody needs. Some people only need maybe 30, 40 milligrams of Valium one day and then less the next. They only need it a couple days. Other people have tremendous withdrawal, and somebody in DTs is going to need tons of IV Valium. I had a patient in DTs that I gave 3,000 milligrams of Valium to in one day, intravenously, 3,000 milligrams. And when you get to that point, all the benzo receptors are kind of full, so it doesn't matter if you give more or not. Clonidine is a blood pressure medicine. It can be helpful for alcohol withdrawal. People that are in DTs, we use phenobarbital because when the benzo receptors are full, we can still use phenobarbital. It goes to the GABA receptor, and the more you use it, the more it'll work. If people are in full-blown DTs, they need to be given something for their blood pressure, and Precedex is used. And then the worst case scenario, we have to put them in a medically induced coma in the intensive care unit. And for that, we can use propofol. So that's treatment of alcohol withdrawal. Any questions about that?
I thought the gabapentin, I didn't know that you guys use the gabapentin for, alcohol withdrawals. I thought that was also for like a pain or muscle.
Gabapentin is an unusual drug. It's an anticonvulsant. It's used for seizures, or used to be used, but it's used for chronic pain.
Exactly.
It's used for anxiety. It's used for alcohol withdrawal. So it's used for opioid withdrawal. So it can be used for a lot of different things. To get people off of the benzodiazepines depends on what the situation is. If somebody is given it for anxiety for many years, say they're on Klonopin, and they just can't get off of it, I can see them in my office and switch them to Valium and then taper the Valium. And it might take a long time. It might take months. It might take a year or more of gradually going down on the taper to get them off. It's called an outpatient taper. If they're using high dosages of benzodiazepines for 3 or more months, they're really addicted to it, then we bring them to the hospital and put them on phenobarbital. The doctor has to know which benzo they're addicted to, because the withdrawal is going to be different from each one. From somebody on Xanax, the withdrawal is going to hit right away and be done in a shorter period of time. If somebody is addicted to Klonopin or Valium, the withdrawal is not going to hit for a week. So you have to be careful that you don't discharge them from detox, send them to Logic Plus, and then they go into Valium withdrawal later. So the doctor has to know which benzo they're on and how long to use the phenobarbital. I had a patient that was on Ativan, 2 milligrams 4 times a day for 5 years. So I put her on phenobarbital, and then I saw her in my office for 8 months, gradually reducing the phenobarbital. And that works very well to get people off of the benzos. There's also a medication called Tegretol, an anticonvulsant that can be helpful for benzo withdrawal. Stimulants. There's no great drug to treat stimulants. Back in the 90s, there was a crack cocaine epidemic, just like there's an opioid epidemic now. So we got a lot of people that were using lots of cocaine, and they had a lot of craving when they stopped, a lot of urges to use. And sometimes I used a drug called bromocriptine, which goes to the dopamine receptors in the brain, and that was helpful. Haven't used it in a while because I haven't seen a lot of real severe cocaine addiction, but it's coming back. Cocaine is coming back. Methamphetamine is an epidemic now too. Tons of people are using methamphetamines. The withdrawal from that, the craving from that is difficult to treat. Around the country, they've used a lot of different medications to try to treat it. There's no good medication for methamphetamine craving. If somebody is still just coming down from methamphetamine psychosis, you might use some Ativan to calm them down, but there's no great need for medication for detox from that. For the marijuana, there's nothing you need to do other than give them fluids if they have that cannabis hyperemesis syndrome. And Zofran is a nausea medicine that you can use. So opioids. Back in the day, there wasn't anything we could do. We could give people methadone, but you can't use methadone works for opioid withdrawal because it is an opioid. The only difference is it can be taken by mouth and it lasts all day. So you only have to give it once a day. So methadone will work, but then you have to figure out what you do when you stop methadone. And we're not a methadone maintenance program here, so that's not an option. Before 2003, we used clonidine. That's a blood pressure medicine. It was pretty effective for opioid withdrawal. It can relieve a lot of those symptoms. But it caused a lot of dry mouth, fatigue, made people dizzy when they stand up. And you can only give so much because it lowers the blood pressure so much. So clonidine was all we used until 2003, when buprenorphine became available. And we actually were the first institution in Minnesota to use buprenorphine down on 3A, down in the detox center in 2003. We gave it to somebody in heroin withdrawal, and it is a very interesting drug. Buprenorphine is an opioid, but it's also a blocker of the opioid receptors. So it stimulates them and blocks them at the same time. So if I took buprenorphine now, I would feel high because I'm not using anything. But if somebody is in withdrawal, you give them a little buprenorphine and it takes them to normal and it blocks the receptors so they don't get high. It works very well for that, relieves withdrawal. You have to wait 24 hours after the last use, or it can make withdrawal worse. That's called precipitated withdrawal because it kicks all the opioids off the receptors. But this works very well. But it was invented for not just detox, it was invented for medication-assisted treatment to help people recover from opioid addiction. We weren't sure about that in 2003. We thought, let's just use it for withdrawal. Let's just give it for a few days and see what happens. Well, they went back into withdrawal. So then I tried, let's just use it for 2 weeks. Well, they went back into withdrawal at the end of 2 weeks. Not bad. We tried different tapering schedules, but they always felt when they came off of it, they had a lot of craving, they were relapse prone, a lot of relapsing, they weren't feeling very well. So buprenorphine does work for withdrawal, but it actually works best when it's used for medication-assisted treatment. Some people simply do not want to be on buprenorphine or a drug that is a little bit of a stimulant. They'd rather be on a blocking drug. And that drug is Vivitrol, which I'll get to in a minute. So if that's the plan, we can't have any opioids in their brain, in their system. So we have to detox them from opioids without using any buprenorphine. And for that, we can use this 3-drug regimen: hydroxyzine, Xanax, and gabapentin in high doses. And I've had people that I've been able to successfully get off heroin over the course of a week with that. And then we can use the blocking drug Vivitrol. So that's how we detox people. After that, they are discharged to treatment. They're discharged to Logic Plus, some are discharged to home. Then they go on, but they're still in this protracted abstinence syndrome. People with opioid dependence are particularly prone to relapse, so we'd like to give them something that helps them be more successful. That's medication-assisted treatment. For the alcoholics, there's an old drug called Antabuse, which I still use, not infrequently. Antabuse is a drug that interferes with the breakdown of alcohol, so that a chemical called acetaldehyde builds up in your bloodstream. That causes a flushed feeling. You get hot, you get sweaty, you get nausea, vomiting, stomach cramps, diarrhea. It's miserable. So people that do not want to drink, that do not want to relapse, they take the Antabuse willingly. They get up every morning, they take an Antabuse, and then they know they're not going to drink that day. If they're tempted to, they remember that they took the Antabuse, and it stops them in their tracks, and then they go to bed, get up the next day, and take the next Antabuse. They do it every day. I've got some patients in good solid recovery that have been on antabuse for over a year. And they just take it as part of their recovery program. And they feel like it gives them a little extra motivation and help. Naltrexone is an opioid blocker drug, but years ago they studied it on alcoholics and found that people on naltrexone with alcohol dependence relapse less frequently. So it's used for the alcoholics. What naltrexone does for the alcoholic is that it reduces the pleasure of alcohol, reduces the reward of alcohol. So when the alcoholic knows that the drinking's not going to give them as much pleasure, they don't drink, and they have a less relapse rate. So naltrexone comes in a pill form that you can take 50 milligrams a day, or it comes as a shot form called Vivitrol. Same drug, it's just in shot form and it lasts all month. Some people that don't trust themselves to take the naltrexone pill, we can give them the the Vivitrol shot once a month. Gabapentin can help this anxiety and the protracted abstinence syndrome that I sometimes use. And then there's other drugs like Topomex and Campril that are available for the alcoholic to help reduce relapse, and I don't use them quite as much. For the benzo addict, there's really nothing to do other than like meditation, cognitive behavioral therapy, counseling to reduce anxiety so that they don't need the benzo. But like I said before, sometimes the benzo taper takes 6 months, 9 months, a year, and I will see people that do their long-term taper. For stimulants, I wish there was a good drug that would help people with the methamphetamine craving. I've seen people come into treatment but leave, and they have such craving for meth, for returning to meth, and there's no great drug like there is for the opiates for that. But I've had a couple people get the Vivitrol shot, get the naltrexone shot, and they said it works for their meth craving. So that's something I've done for some people. Sometimes it's hard to get the insurance to cover it, but it is an option. And then an antidepressant called Wellbutrin has also been used for meth craving. Marijuana, there's no drug for medication-assisted treatment. But opioids, there is. And that's the chemical for which medication-assisted treatment is probably most needed and most helpful. With opioids, there's such a high relapse rate. There's such a pull back to using the drug. Any particular cue, trigger will pull them back to using it. It's so easy for it to happen. Since the 1950s, methadone maintenance has been available, and some people have made that work. They just go to a clinic, get their methadone, and take that every day. And some people, they go to a good clinic, they make it work. Other people go on methadone maintenance, and it's not healthy for them. They're in parking lots and waiting rooms with people that are not good influences on them. The methadone makes them feel high or sick or drugged out in the morning before it wears off. They don't like the long-term effects of the methadone, and they have a lot of trouble getting off of it. We don't do methadone maintenance here, but I just wanted to mention that it is available. Vivitrol is the opioid blocker. We can get somebody off of all the opioids for 1 or 2 weeks. We can give them a shot of Vivitrol, and then they can't use for a month. If they did use, nothing happens. All their opioid receptors are perfectly blocked. They cannot use. It just won't work. So they know that, and so they won't go out and seek the drug, buy the drug, use the drug. It just doesn't make any sense. The key challenge for Vivitrol is to come back for the next shot, come back for the shot after that, for the shot after that. That's where the challenge is. And a real motivated person, actually some people with a lot of reason to stay sober, like they're going to lose their marriage, their job, their license, doctors, lawyers, airline pilots, nurses, whatever. They have to stay sober. They get the shot. They have to get the shot, and then they can make that work. Buprenorphine, like I say, became available in 2003, and this is probably the most effective medication-assisted treatment drug for the opioid addict. It's combined with naloxone, and the major form was Suboxone. Now it's generic. Zubzol and Butavale are just other forms of the same drug. People can go on buprenorphine, they get started on it after detox, it makes them feel normal. They can go to a good provider, addiction provider, or some family medicine doctors prescribe it and they know about it. And they can stay on it until they put their lives back together. It doesn't work if it's used just by itself. If somebody just goes on Suboxone and tries to live without any kind of recovery program, it almost always fails. Just like if somebody tries a recovery program without this, it frequently fails. But both of them work quite well. There's sometimes a 70–80% success rate if both are used. It's medication-assisted treatment, not medication instead of treatment. But buprenorphine works. It takes a good Suboxone addiction doctor to know how much to give, how long to give it, when to wean it, how to wean it, what to do in problem situations, what to do if you have surgery. So you gotta have a good doctor, you gotta take it as directed. Some people go on it and it makes them feel normal so that they can put their lives back together, go to school, get jobs, raise their family, and then they can work the recovery program and then over time, slowly come off of it. And I've taken many people off of it without a problem. Down at the end, you get down to very tiny dosages of the buprenorphine, little slivers of the strip of Suboxone each day, and then they can come off. And now there's injectable buprenorphine called Sublocade, where the person can get the shot once a month. It's the same medication. It's just an alternative way to take it. So that's buprenorphine, that's medication-assisted treatment for opioids. Any question about any of this?
Yeah, I have a question. For stimulants, like, would it be recommended to, like, without drugs, recreating some of the same effects that they do give you by, like, exercise and things of that nature to kind of lift the heart rate?
Not heard of that.
And then
I don't think it's the same. I don't think just increasing the heart rate through exercise is the same effect the brain gets from using the
yeah, and then so with the stimulant use over an extended period of time and having like abnormal heart rate and things of that nature, would you be more prone to cardiovascular issues post?
Not so much post. Not so much post. If you can survive your meth use, survive your cocaine use, you haven't had a heart attack or stroke or anything during the use, you should be okay subsequently if you stay sober.
Is it possible to get all that on paper? Do you have copies of that on paper?
Take a picture of it.
On camera.
It's on film. Somebody's gonna put it on YouTube.
Awesome.
Yes.
Okay, with the Klonopins, the benzols, the hydroxyzine, when you were treated with, to come in here, had to get off the Klonopin. So how long does it take the effect of the hydroxyzine to get into my system? Do you know what I mean?
Yeah, hydroxyzine.
For the anxieties and.
Hydroxyzine is an antihistamine, and it has anxiety relieving properties. It's not addicting. So it's an acceptable drug to use for anxiety as you're coming off of the benzos, but it works right away. It should work right away.
It's not.
going to work. It doesn't have to build up. Anything else?
Yeah. It's been suggested to me that Suboxone for pain management. How's that?
Question was Suboxone for pain management. It works very well for pain management. And a lot of the pain doctors locally and nationwide are using it more and more for chronic pain. When people have true chronic pain, then they're prescribed the regular opioids. After a while, the opioids don't work, and the opioids actually create pain by causing opioid-induced hyperalgesia. The opioids actually make the brain make pain. Suboxone doesn't do that. Suboxone is less used, but so it works very well for chronic pain, and it's used particularly in addicts with true chronic pain.
What happened with Subutex?
Subutex is just pure buprenorphine. It's still available. You can prescribe it. Every once in a while, somebody is allergic to naloxone when you use it. We still use Subutex in the pregnant patients. But the naloxone that's in the Suboxone and the other ones does not really get absorbed. It doesn't get absorbed under the tongue, doesn't get absorbed if you swallow it. So it's just put there to prevent people from injecting that product. Then they would go into withdrawal. But otherwise, Subutex and Suboxone are the same.
What about someone who abuses like gabapentin or Lyrica? Like what category would that fall under?
Yeah, that's a good question. You know, addicts will try anything to abuse. So some addicts will abuse Seroquel, some will abuse Wellbutrin, some will abuse Trazodone, whatever. Gabapentin you can abuse, and there have been cases of people seeking and taking tons of gabapentin. Probably makes them feel kind of like a benzo, a little relaxed, a little sedated, a little high. I don't see a lot of it, and I don't withhold gabapentin from a person with addiction. I've been pretty comfortable prescribing it, so it's pretty rare that somebody gets addicted to it.
Is it true it's a natural root? Gabba, that's what I heard.
A natural root?
Yeah.
I don't know.
That's, well, I did some research on it. Yeah. Anyway, okay.
Yes.
Dr. Amer, we had a conversation in one of the groups last week about Trazodone versus Seroquel as a sleep medication, which works better. What is your opinion about that?
Trazodone is an old antidepressant. One of its side effects is it makes people drowsy. So over the years it has become used for sleep. Seroquel is an antipsychotic invented for the treatment of schizophrenia. One of its side effects is that it makes people tired, so it becomes used for sleep. I think Seroquel is too big a drug to use for sleep. It's effective if somebody has lots of anxiety, maybe bipolar, and they need it for other reasons, then it's fine, but it's a big drug to use for sleep. Trazodone's not as big a drug, not as dangerous. I think it's more safe than Seroquel. But obviously the best is just learn how to sleep without it.
Where does mirtazapine fit in all
The question is mirtazapine. It's very similar to Trazodone.
this?
It's an antidepressant, causes sedation, but it's a good antidepressant. Anything else? Okay, thanks. All right.